Welcome back to Beyond Well. I'm Sheila Hamilton, and today we're going to be talking about a topic that I think is one of the most interesting in the time that we have actually been discussing the use of psychiatric medications. And this is with Dr. Jennifer McLaren. She's an assistant professor of psychiatry at the Dartmouth Institute for Health Policy and Clinical Practice. Dr. McLaren's practice focuses on caring for kids, adolescents, and adults with autism and neurodevelopmental disabilities. And Dr. Erin Barnett is an assistant professor of psychiatry in the Dartmouth Institute for Health Policy and Clinical Practice. Erin's expertise and interests lie in child trauma and adversity and the psychosocial and pharmacological services provided to that population. So thank you both for joining us, first of all.
Thank you for having us.
And Dr. Barnett, I want to start with you. This is a particular population that I'm extremely interested in dealing with families that come in contact with the child welfare system and in the foster care system. Can you tell me, first of all, about the percentage of foster care kids and kids that are in the system that actually take a psychotropic medication right now?
Sure, yeah, the rates really are variable depending on the data set and the state and the region where the child lives. So most estimates are somewhere between 14 and 40% of children in foster care are receiving at least one psychotropic medication.
And how does that compare to the general population?
Most recently, the Medicaid population in the country shows rates between 6 to 9%. So as you can tell, it's at least double, probably more like triple of the Medicaid population.
So I can imagine as a researcher that you're seeing these very, very high numbers and that there's data to support that these kids have the kind of behavioral problems that need this. What is your hunch as a person who's worked with these kids for this long about what's really going on?
Right. So, of course, we would expect more mental health services, including psychiatric medications, in populations with more mental health problems, behavioral disorders. And so it's not a surprise that the children in foster care who have had a lot more stress and have a lot more behavioral health symptoms because of the context of their everyday life and abuse and neglect that they have incurred. So, of course, we would expect them to have a little bit higher rates than the general Medicaid population and potentially higher rates, than the general child population, period. But everyone realizes that they shouldn't be this high.
Yeah.
We have, good literature to support certain types of medications for certain diagnoses and symptoms, and the rates do not correspond. So what I mean by that is the rates of medications used do not correspond with the diagnoses we see when we pull big data sets and look. So, For example, atypical antipsychotics have a few indications, are approved by FDA for a few small things that are quite rare in children, and yet we see that that's sometimes the second and third most common type of medication used, and it just doesn't make sense.
Wow. I also want to get Dr. McLaren on the line to just talk about deprescribing. We don't hear that word used very often, so talk about it, what that means with particularity to this vulnerable population.
So deprescribing is a term that has been really first used and disseminated in geriatric medicine. There's been clear evidence that deprescribing can be helpful in patient populations who are over-medicated. And it's a systematic removal of medications over time. And we're particularly interested, our group, about deprescribing of psychotropic medications. And our proposed study is deprescribing of antipsychotics in children who are treated with them for off-label uses. So they don't have a clear indication of why they're taking these medications, and we believe that they may be causing more harm than good.
What are the barriers, Dr. McLaren, and the facilitators of deprescribing, according to the clinicians that are doing the prescribing?
I'm going to let Dr. Barnett discuss that because she actually just did a study on the barriers and facilitators to deprescribing.
Yeah, we have been hearing a lot anecdotally from pediatricians and child and adolescent psychiatrists. Our research team has a lot of connections locally and across the country, but we decided we needed to really systematically try to capture the perspectives of prescribing clinicians. So we did a nationally representative study of both primary care pediatric prescribers and those sitting in specialty mental health clinics, mostly child and adolescent psychiatrists, and we asked them using qualitative interviews. And the number one concern and barrier that they noted was actually parent resistance. So again, this is from their perspective, right, that they're worried that parents will push back and fear what might happen if we started pulling back the medications in the children, even though, remember that these medicines are not being used in an evidence-based way in the first place, right? Wow. So they're not indicated to start with. And, polypharmacy, more than one psychiatric medication is not indicated or evidence-based either in almost every scenario.
What are some of the risks, especially because what I've witnessed is if kids start out early, say, for instance, on an ADHD medication, that they might be given a mood stabilizer to couple on that as they get older, and then maybe an anti-anxiety or antidepressant on top of that as they even age out. And so I'm very curious what some of the difficulties have been when you see this kind of layering of all of the medications on this population of kids.
I do know that we see that cascade of medications being used, and sometimes they're to manage the side effects of the first medication.
Right, yeah.
And one thing we noted from our research is that clinicians don't slow down to think about how the child may have developed or changed and might not need the medicine anymore, right. And parents don't slow down to do that. So they cascade. Maybe they're getting the prescriptions from different prescribers along the way as well, especially those who are involved with various systems and those in foster care who are moving homes. We hear also, and our study showed that the doctors may not feel comfortable and know how to deprescribe. They don't know the first reason why the child was put on it, and so they're hesitant to take it off. Oh. And some literature and some guidance and some algorithms could be really useful. And Dr. McLaren and another one of our partners, Dr. Concepcion, actually developed some guidelines that we're hoping to be able to pilot test.
Dr. McLaren, can you speak more specifically to those guidelines? What would you like to see happen?
Well, I just want to go back to your previous question. We are certainly clinically seeing these kids who are started on medication for ADHD, and lots of other medications are being layered on. Mm-hmm. And it's not uncommon that some of the medications are being utilized to treat challenging behaviors, and that not necessarily other evidence-based interventions are being utilized in this patient population. And there could be more than one prescriber involved, and then the child comes into your office, and sometimes the medications are causing more side effects than any good. So we thought over time that we need to sort of think about how can we help people systematically remove medications, and we explored the literature and saw that there wasn't clear guidelines on how clinicians can do this in an outpatient population. So we developed this protocol, and we'd like to sort of test the implementation and feasibility of the protocol about how to systematically deprescribe antipsychotics in youth. And hopefully we can test this and then do a larger study to then start disseminating this protocol to help children come off of medications like antipsychotics.
Wow, this is so important. Can you talk more about this specific proposal?
Yeah, so our proposal, we really have designed a structured protocol to guide clinicians on how to taper and eliminate antipsychotic medications. And it's based on available evidence in the literature, and a lot of the literature comes from adult populations. So we're proposing a preliminary feasibility study on our intervention, sort of as a first phase in other evidence-based practices. The initial phase is going to gather preliminary evidence on the implementation, feasibility, and safety of deprescribing off-label use of antipsychotics in children receiving care at community mental health centers. And we'd like to study this in 10 children.
10 children. And the link right now that you have with the Foundation for Excellence in Mental Health Care is to gain support for this particular inquiry?
Yes, we need support to implement this study and to help fund the study.
I want to give people more specific steps about how they do that. The foundation is this excellent resource for researchers like Dr. McLaren and Dr. Barnett to be able to do this really groundbreaking work. And what you do is you go to the Foundation for Excellence in Mental Health Care's website, you scroll through to the funding options, and you can read more about this policy and what the doctors are proposing there. And this is where regular individuals can get involved and really shape the future of what our research looks like, correct?
Yes, we hope to.
Yeah.
And we hope as part of this study to understand both the parents and the prescribers' perspectives on how the deprescribing intervention was, both at baseline and at the final assessment.
I want to just talk a little bit further about how ingrained this is, because the recommendations for this kind of use of multi-layered medication runs through Health and Human Services, it runs through Medicaid, it runs through child welfare agencies, mental health officials. And so in some ways, it feels like you're pushing a huge Sisyphus ball up a mountain, because this the regularity with which especially vulnerable populations of kids are overdrugged is really ingrained in a system. Do either of you want to speak to that?
Yeah, and unfortunately, we feel like the systems sometimes are not always working. They're siloed, they're fragmented, and sometimes it feels to me that we've become a drug culture, and sometimes we're looking for the magic pill to fix something that other interventions may take longer, maybe more work, but also maybe more effective and safer.
Yeah, Dr. Barnett?
You're absolutely right that this is a huge uphill battle. We've sort of sunk into this idea that the medical model is going to fix symptoms and behaviors and stress and trauma. And as we talked about earlier, a lot of these children are traumatized and have had incredibly high adversity throughout their lives. And so sadly, in our U.S. culture and elsewhere, we have tried to apply the medical model where it's not a good fit, and we really feel like this is going to be a culture shift, and it's going to take not just provider education, but parent and community education, right? So sometimes schools are asking us for the meds, sometimes parents are asking doctors for the meds, and we believe they're just misinformed and wrongly educated. And we think if we can get the right education out there on a bigger level, that we can shift back to the sort of the biopsychosocial model.
Wow, it's a fascinating project and one so worthy of our support. Do you have anything else that you want to add that I might have missed?
Well, we also surveyed parents. Dr. McLaren has information right in front of her, so I'm going to let her tell you a little bit about that.
Yeah, Dr. McLaren, go ahead.
So we surveyed a group of 48 parents who were treated with their children were treated with either antipsychotics or the off-label use of multiple psychotropic medications, so 2 or more psychotropic medications. And of those parents, 42% noted that their child stopped medications early, and half of those parents, so 50%, expressed interest in participating in a deprescribing study. Wow. And half also said that they were interested and were concerned about stopping medications due to the harmful effects of the medications. And then we also had almost 60% said that they felt like their child's prescriber should review the effectiveness of their child's medications. And half felt like their children's medications were not working.
I'm so fascinated by this, especially with the additional information from the GAO that said that for most of the foster children, they were on, or at least I think it was 13 to 15% were on 3 or more drugs at one time.
Yeah.
So there's got to be so much confusion by the part of the parents in saying, I don't know which one is causing the good behavior and which one is causing the bad.
Yeah, it's like what came first, the chicken or the egg?
Exactly.
Are any of the medications really helping?
Wow, it's a really fascinating project, and thank you. I really appreciate it, Dr. McLaren and Dr. Barnett.
Thank you very much for taking your time to interview us today.
And if you want to find out more information and support this policy work, you can go to the Foundation for Excellence in Mental Health Care website, or you can click on the link now and become a sustaining member.